I would like to show you now a live case where we recently analyzed different forms of lesion preparation. This is the topic of my presentation. I would like to show you different ways how we can probably prepare lesions in the SFA and the popliteal artery, and discuss a little bit on these different ways of lesion preparation. So the case I would like to present you is a case of a 77-year-old patient, Rutherford 3 on the left side predominantly, even that he has lesions on the right side. Left side was predominantly the more sicker side. So this patient was scheduled for an up and over maneuver. You could see here the crossover maneuver, which was not actually easy because of a lot of calcified disease. So therefore we used here the Oshkosh sheath, as you could see. And you could see here long lesion situation, calcified lesion in the SFA, predominantly in the middle and in the distal part. The main issue here in the popliteal segment 1, 2. So a very important area where we definitely want to prevent stent implantation. We know from the past that POBAR is, of course, a way how we can prepare lesions, but we know that standard balloon angioplasty is associated with a lot of complication in terms of dissections, in terms of recall, or any more complications, which then force us to implant a stent. Therefore, I personally believe an intensive lesion preparation is important, meaning different devices like atherectomy or scoring. Here I would like to show you the CSI device, which we used to perform lesion preparation in terms of atherectomy for treating here this highly calcified popliteal lesion. The device is an orbital atherectomy device coming with different sizes of catheter. This is the 1.5 catheter from CSI. This is the driving machine, as you could see here. And this diamond-shaped distal part of the catheter is now advanced into this lesion, as you could see here. And this tries to gain lumen. Of course, lumen gain is one part of the story, but the other part of the story to improve the vessel compliance. And this means that we then afterwards only need to use very low atmospheres with ballooning, like a drug-coated balloon, and with that hopefully prevent dissection, which then forces for stent implantation. As we are aware, there are a lot of different atherectomy systems on the market. We definitely need now to learn which could be the best option in which indication. Highly calcified lesions are definitely the most challenging lesions. So orbital atherectomy is, from my point of view, a very good option, especially in these kind of lesions. You see here that we pass the lesion with different approaches, starting always with the lowest rotation through this lesion. So starting with 60,000 rounds per minute. And this diamond-shaped catheter really works on the surface of the calcium and then creates a lot of powder, which is just flushed out into the microvascular bed and out of the artery. And this is the principle of that. You don't need a filter. You don't need any other expensive the devices to prevent actually a distal embolization. Distal embolization is definitely not a problem with the device. You now see after usage of the CSI catheter that we already gained some lumen. Definitely then we went for drug-coated balloon. And if you look here at the manometer of my inflation, you could see that we only used 4-6 atmospheres. I show you the outcome of this popliteal segment in a second, but I first would like to, here is the outcome, then show you what we did in the rest of the SFA, just to show you that with different strategy of debulking, we are not always getting the best result. Here the popliteal artery after DCB, after atherectomy looked very well. But what about the rest of the SFA? Here we then used a different approach, just to show you that there is a different outcome between different lesion preparation devices. In the SFA, we now going to use a device, a scoring technology device from BD Bart, UltraScore device, a scoring technology, a balloon with double wire around the balloon. Here you see the device in the distal SFA and the mid SFA. This is a 200 millimeter scoring balloon. And you could see now on the manometer that I needed to inflate this balloon much higher than I had to inflate the DCB after atherectomy. Here, I needed at least 10 atmosphere to fully open that balloon, meaning to crack the calcium. And this, unfortunately, led then to more or less severe dissection in the middle part of the SFA, meaning that the scoring technology did not improve compliance that much as the atherectomy with the CSI system did. Of course, also here I used DCB angioplasty. This was a Lutonix drug-coated balloon, and here's the second one. So we DCB'd the whole SFA tract, but we had still that remaining dissection in the mid-SFA. And this then led to scaffold implantation. And in this particular case, I decided to implant TAC devices. But if you compare that lesion preparation outcome in the popliteal with the SFA, here, I definitely have to admit it would have been great also to prevent scaffolding here. So it seems that there are different outcomes between different lesion preparation strategies. And I think that's something we need to learn in the future and set up trials, which could be the best option in which indication to avoid stent implantation or scaffolding at the end. Here, this is after the TAC implantation. This is the post-ballooning of the TACs here after implantation. It is not a standard stent. These are just 6 millimeter stents. The final result was very good. Also, the popliteal artery, there was no recall, there was no dissection, very good outflow in the single vessel run of the patient had. And so at the end, we had a very good outcome. Thank you very much.